Thank you. Everybody knows.
Oh, yeah, and if you wanna put this over here,
I don't know what it's called.
you can't.
No. Yeah. Hey, I
So
thought that was
cool.
It's insane.
It puts things into the different. Like it like organized HVAC and planet.
Yeah, so we should get rid of something. We need the patient interaction, right? Diagnosing you, your code.
I did. You did the first day.
What's your plan?
You showed me how it generated it, just because I showed out like very little bit of stuff. I was like, this is what I'm gonna do the rest of my life. That room to the time you walk, like empty. So I just be like, or this, I think this. And he's like, good, let's go. Very good. That was only.
So you're like rest.
From 7:30 in the morning till 5 now.
Wait. Sure, that's so weird. That's a location.
Yeah.
Yeah.
How old? Old, pretty young. Graduating like that.
So it's one you just gave yourself for like,
He loves work, is what he would say. He loves work. I imagine.
be fair, I mean, the RVs are good. Stay on the ride. Can't believe it's not gonna pay for itself.
I see like 5.
Once email cracked me up, it's like surgery.
Yeah, I'm sorry, I'm an idiot.
I was looking on my phone, just scroll over, it was like scrolling up my phone, I immediately texted her.
He's not shy on it.
One was actually.
Yeah, we go triple that.
That's it.
No, I went today, yesterday.
But are you not at the leadership event?
I had to go to the beach, I'm in Utah.
I didn't see you break this.
Yeah, so I was looking yesterday in the morning, from UConn, and then he went to Edmond, and so then I was with the other dogs at UConn.
Oh,
Which one was the so maybe I wanted Edmond in the third week. You can see where I'm going first.
Yeah, that's what, well, he said.
So that's still
Yeah.
Are you all ready?
which stuff is that?
Can we get started?
Cameron's also. Right, I see now they're.
I worked right last year because the door was closed. Maybe.
Sorry, I'm there. Early
There's
use
just no
use
internet.
it. I don't know if they're gonna use
You snack commercials, I forgot about that.
These are the objectives of today's lecture. we'll discuss essentially hypertension and diabetes. And how do you diagnose hypertension? And what is the evidence-based plan of treatment for both diabetes and hypertension? Okay. And this question is for you. This is a gentleman like Bob, who is your longitudinal patient, who complains of increased thirst and increased urination. And how can he be diagnosed with type 2 diabetes based on which random blood sugar level? And what would be your answer?
E.
I'm sorry?
E.
E. That is correct. Random glucose level of 200 milligram per deciliter or greater in the presence of symptoms is diagnostic of diabetes. A fasting blood sugar of 126 milligram per deciliter or greater is diagnostic of diabetes. An A1C of 6.5 or more on 2 successive occasions is diagnostic of diabetes. Okay, let's keep that in mind. And this question is, which is the best first-line therapy for type 2 diabetes with an A1C of 8? And what would be your answer?
A.
Yeah, metformin is the right answer. Metformin is the medication most commonly used in type 2 diabetes. Most patients with type 2 diabetes produce enough insulin. So what metformin does is it enhances the activity of insulin in the pancreas. And it also prevents glycogenolysis. Okay. So those are the two mechanisms of action of metformin. So metformin is the medication of choice in patients with type 2 diabetes with an A1C of 8 or less. Obviously, diet and exercise also is an integral component of treatment of diabetes. But usually when the A1C is 7 or less, I think it's reasonable to initially start them on dietary modifications and regular exercise. But once the A1C is consistently above 7, then it's time to start medications. And what diagnosis best explains Bob's symptoms of increased thirst and frequent urination? And again, that would be type 2 diabetes. BPH does cause frequent urination, but it shouldn't cause frequent thirst. UTI will cause frequent urination, but there's no association between that and thirst. And hypertension and low back pain have nothing to do with frequent urination or increased thirst. And again, this question also addresses the diagnostic criteria for type 2 diabetes mellitus. And again, what would be your answer? E. So this addresses another criterion for diagnosing diabetes mellitus, which is an A1C greater than or equal to 6.5%. On 2 occasions, it has to be done on 2 occasions. If it is just on 1 occasion, then you'll have to wait to repeat the test. Okay. And again, this slide outlines the diagnostic criteria for diabetes mellitus. One is an A1C of 6.5 or greater, fasting plasma glucose of 126 milligram per deciliter or greater, a 2-hour postprandial glucose of 200 milligram per deciliter, a random plasma glucose of greater than 200 milligram per deciliter in the presence of classic symptoms, polyuria, polydipsia, polyphagia, weight loss, stuff like that. Is there any way of increasing its size? Maybe this.
Definitely application mode.
I'm sorry?
If you go to slideshow up top, on the very, like, next to, in between animations and record, like left more, or. Oh, you know, to do it down there. Okay, yeah, sorry, that's the easier way.
I did. Okay, let's see if we can get it done a little slower.
I think it's just go to.
Yeah.
Setting point slide.
Yeah, this will work. Okay. And again, this addresses another group of people who are pre-diabetic. That's between normal and diabetes. And these are a subset of people who have an A1C of between 5.7 to 6.4, whose fasting plasma glucose is between 100 to 125, and on an oral GTT of between 140 to 199. Okay. And if you don't intervene at this time, many of those will become diabetic. If you intervene, there is a slight chance, or there's a definite chance that they won't progress becoming diabetic, but they may even revert to normal. And what are the most common associations with prediabetes? Obesity. Okay. So again, weight loss will definitely cause them to revert to normalcy and minimize the progression to diabetes. Sometimes certain medications like pioglitazone or metformin can also help with that in preventing the progression to diabetes. Now, what are the management goals in patients with diabetes? An A1C less than 7 in elderly patients or in patients with multiple medical problems. An A1C of 7.5 or even 8 is all that you need. You don't have to aim for an A1C of 6.5 or less in those patients. Especially in patients over 65 with stable disease, 7.5 is all that you aim for. And the reason is simple. The more medications you put them on, or when you increase the dosage of the medication, it interferes with their appetite. And it interferes with their nutritional status and causes them to lose weight. And that impacts negatively on their longevity. So in people over 64, especially in people over 70, you focus on the nutritional status and you focus on their able to maintain weight. And you don't focus that much on tight control of the diabetes. Whereas in younger people or people who are highly motivated, you can aim for a much better A1C of 6.5 or 7. A1C is generally monitored every 3 months. But if you have good control of diabetes, it's enough to do it every 6 months. It's not necessary to do it every 3 months. As far as blood sugars are concerned, you're aiming for a pre-meal of between 80 to 130 and post-meal between 140 to 180. In fact, if you see your patients wearing a continuous glucose monitor, the CGMs, you will know it is set between 70 to 170. And what they are aiming for is to have at least between 80 and 90% of the time between those two values. So if they are able to maintain 80 to 90% of the time between those two values, that means they have met their management goals. Obviously, what's going to happen is after you eat, you're going to see some peaks. And sometimes those peaks can go up to 200. But as long as it is a clear mountain, it comes down quickly, that's fine. Okay. Which of the following is recommended for patients with type 2 diabetes? Don't be shy.
B.
D. Diabetics should get a pneumococcal vaccine at the time of diagnosis. The next time they'll get it is at the age of 65. You need to do the monofilament testing to check for neuropathy every year. Finger stick blood sugars are done probably twice a day. Fasting and 2 hours postprandial is all that you need, unless you're on insulin. When you're on insulin, you need to check it pre-meal. And of course, definitely you need to check it fasting. And some people say you need to check it late in the night as well. Okay, so 4 or 5 times a day. Annual dilated eye exam is recommended at the time of diagnosis in a patient with type 2 diabetes, and within 5 years of diagnosis in type 1 diabetics. A1C is recommended every 3 months. And if you have good control, 6 months is enough, every 6 months. You should always screen diabetics for comorbid illnesses like hypertension, dyslipidemia, hypothyroidism, smoking, and depression. And you should also screen them for celiac disease in patients with type 1 diabetes. Keep that in mind. Hypertension, dyslipidemia, hypothyroidism, smoking, and depression. All type 2 diabetics should be screened for them. You should also screen for complications, retinopathy, nephropathy, and neuropathy. Neuropathy can be polyneuropathy, or it can also be autonomic neuropathy. And autonomic neuropathy presents as erectile dysfunction, postural hypotension, poor gastric emptying, which leads to bloating, abdominal pain, and vomiting. Okay. And diabetics are also at an increased risk of coronary artery disease. So they should be screened for CAD, coronary artery disease. Diabetics are at an increased risk of infections, which is why they should have the flu shot every year. They should have a pneumococcal vaccine at the time of diagnosis, then at 65. They should also get hepatitis B vaccines, Tdap, Zostavax, as well as the Shingrix. But that is not specific for diabetics, that is specific for the general population, okay, and not specific for diabetics. How can you prevent complications of diabetes? Or even if you're not able to prevent, how can you delay complications of diabetes? One is excellent glycemic control. Every 1% reduction in A1C is equivalent to a greater than 20% decrease in complication rate. Blood pressure control. People who are diabetics, especially those with nephropathy, need excellent blood pressure control and should have a blood pressure control to 130/80. They should all be on statins, especially those 40 and over, to control dyslipidemia. They should all be encouraged to stop smoking. They should have healthy lifestyles and be extremely active. And they should all be on aspirin to prevent cardiovascular complications. These are the various classes of medications in treating diabetes: the biguanines, thiazolidinediones, sulfonylureas, meglinitydes, alpha-glucosidase inhibitors, insulin, and the GLP-1, the DPP-4, and the SGLT2. You will hear a lot about GLP-1s and SGLT2s going forward. And this question is for you. Which of the following medications affect B12 levels, necessitating monitoring? And your answer is?
Metformin.
Metformin. Metformin at a daily dose of 1500 milligram or more does affect B12 levels. So it's important to monitor B12 levels and to replace them when the dosage is 1500 milligram or more. Okay. It's a biguanide, and it's a medication of choice in type 2 diabetics, unless contraindications exist. When people present with type 2 diabetes, 1 in 10 are already not producing enough insulin, and you call it primary failure. Those patients do not respond to oral hypoglycemics. Okay? 90% of type 2 diabetics will respond to oral hypoglycemics. Of those who respond to oral hypoglycemics, a further 10% will burn their pancreas out completely and will no longer respond to oral hypoglycemics and need insulin later on in their life, and you call it secondary failure. So keep those two terms in mind, primary failure and secondary failure. So when people talk, this is what they mean. Metformin decreases glucose production in the liver, and it sensitizes the insulin which the body has already produced. And as I said, it's a drug of choice in patients with type 2 diabetes. It can be used during pregnancy. You have to use it with caution in elderly patients, in patients with renal dysfunction, poorly controlled congestive heart failure, and poorly controlled liver disease because of the increased risk of lactic acidosis. You have to stop it prior to patients getting IV contrast, and you should not use it for 48 hours afterwards to minimize the renal induced contrast-induced nephropathy. Do not use metformin if the initial GFR is less than 45 ml per minute. And if the GFR reduces to less than 30 ml per minute, you have to stop metformin. And again, check for B12 deficiency in doses greater than 1500 milligram per day. There is a little more information there, but I just highlighted the most important ones. And again, this question is for you. A 66-year-old man with diabetes mellitus and hypertension presents to you following hospitalization for a TIA. Which of the following agents may reduce his risk of stroke and myocardial infarction? This is very specific. This beneficial effect is very specific for one group of oral hypoglycemics called thiazolidinediones. They do reduce the risk of stroke and myocardial infarction. So in case you don't know the answer, Actos is the right answer. Thiazolidinedione, like metformin, is another insulin sensitizer, and it decreases gluconeogenesis. You should use it very cautiously in patients with class 3 or 4 congestive heart failure because it causes fluid retention. So it can worsen congestive heart failure. And also avoid in patients with significant liver dysfunction. And this question is for you. A middle-aged man with newly diagnosed diabetes mellitus and hypertension already has chronic renal insufficiency with a creatinine of 2.4, probably stage 4 CKD. Which medication of the ones which are listed, which medication would you like to start him on? Again, another class of medications is preferred in patients with renal insufficiency, where you cannot use metformin, or no, but probably you cannot use medications like Januvia, and that would be your glipizide. Okay, sulfonylureas are preferred in patients with renal insufficiency. There are two sulfonylureas listed here. One is glyburide and the other is glipizide. Glipizide is preferred over glyburide because it's the second generation of sulfonylurea, whereas glyburide is the first generation sulfonylurea, which unfortunately produces breakdown products that can cause significant hypoglycemia. So glyburide is not preferred, glipizide is preferred in this subgroup of patients. The sulfonylurea stimulate the pancreatic beta cells to release insulin. Like insulin, they also cause episodes of hypoglycemia and weight gain. And of the ones which we listed, glyburide or glipizide is preferred, as is glimepiride, which is also second generation sulfonylurea. But glyburide is not preferred. There's some association with increased osteoporosis and fractures in women. And this question is for you. A 43-year-old Hispanic male with type 2 diabetes and a BMI of 45 is on metformin. His fasting sugars average 150 and his postprandial is 220, A1C is 9. Which of the following would improve his postprandial sugar and help with weight loss?
Okay.
Exenatide, Byetta. And these are, this is one of the new kids on the block, GLP-1 receptor agonists. Seems to work very well, especially in controlling sugars, as well as in helping with weight loss. And one of the ways they act is to delay gastric emptying. So less food goes out of the stomach into the intestines, and the sugars are absorbed extremely slowly. So it gives more time for the medications that the patient is already on to act. So thereby, they control the blood sugar. And by delaying gastric emptying, it gives you the sensation of satiety, of fullness. So the patient is less likely to eat more. And thereby, it helps with weight loss. You have other examples, Victoza, Trulicity, and Ozempic. And Ozempic and Trulicity are the ones which are very highly favored. They're extremely expensive, unfortunately. Some of them, at least one of them, should be injected every day, but most of these medications are just weekly injections. You cannot use them in isolation. You have to combine them with another medication. For example, the most common combination is metformin with the GLP-1. Which of the following has the advantage of weight loss, but could also cause pancreatic cancer? And again, that unfortunately is one of the side effects of GLP-1s, can cause pancreatic inflammation and occasionally pancreatic cancer, potentially cause pancreatic cancer. GLP-1s potentiate insulin secretion, suppresses postprandial glucagon secretion, and slows gastric emptying, and promotes satiety. They do have side effects like nausea, vomiting, diarrhea, weight loss. Sometimes the nausea and vomiting can be intractable. And if you look up on the internet, there is already a class action suit against the GLP-1s, against Ozempic, that is going forward, because there is a series of patients who have lost a tremendous amount of weight not because of the GLP-1, but because of the fact that they can't eat. Because in spite of stopping the GLP-1, the effect seems to continue. Now the question is there something else going on? But it doesn't take much for a class action suit to go forward. So I just wanted to, so the way I look at it is never be the first to start a patient on a new medication and never be the last to pull the patient out of the medication. Okay. So it's better not to be adventurous with many of these new medications. But for now, it's a lot of people are demanding it, and it seems to do a lot of good. But I just want to make you aware that there is something else going on. So side effects, as I said, include nausea, vomiting, diarrhea, weight loss, pancreatitis, hypoglycemia, especially when combined with sulfonylureas, and there is an increased risk of thyroid C-cell tumor. Okay. It's category C in pregnancy. You've got to be extremely cautious when using it during pregnancy. Pregnant women need to put on between 20 and 40 pounds. You don't need them to lose weight. That's the last thing they need. Another class of drugs is the DPP4 inhibitors. That's your Januvia, Tregenda, Onglyza, and Nacina. Of these, Januvia is the one which is heavily favored and widely used. It's unfortunately extremely expensive, but it's weight neutral. One of the side effects is joint pain, which, interestingly enough, you do see pretty frequently, and it can be debilitating. Especially when they are older, you are thinking of other forms of arthritis. But in spite of adequate treatment, if they don't respond, you've got to consider that to be a medication side effect. Okay. The other class of drugs which has come to the forefront recently is the SGLT2 inhibitors. That's another class of drug which is extremely expensive. Of the ones which you see there, Jardiance and Farxiga are the ones which are most commonly used. Farxiga comes in 5 and 10 milligrams, and Jardiance comes in 10 and 25 milligrams. And cardiologists favor them because of the beneficial effect not only on the heart, but also on the kidneys. And you don't have to be a diabetic for them to start you on Jardiance or Farxiga. In spite of the fact that they are not diabetic, if they have coronary artery disease, especially congestive heart failure, they would benefit from being on one of these medications. They have lots of desirable side effects like decreasing weight, decreasing blood pressure, increasing HDL cholesterol, and decreasing risk of MI, stroke, and cardiovascular death, and improving renal function. They do have some undesirable side effects like B12 deficiency. They may predispose patients to DKA. Keep that in mind, especially people who have been started on them maybe for a few weeks can present with this unfortunate complication of DKA. And because SGLT2 inhibitors increase the renal excretion of glucose, there is an increased risk of UTIs and genital infections. And there's a very rare complication cause called necrotizing fasciitis that can also occur in these patients. But you need to know all about the SGLT2 inhibitors as well as the GLP-1s because they're heavily favored because of their beneficial effects on both the heart and the kidneys. And SGLT2 inhibitors do promote some weight loss, but not to the extent that the GLP-1 does. Combination therapy. Initially, when you have a newly diagnosed type 2 diabetic, depending on how severe the presentation is, most patients you would start out with dietary modifications and exercise and probably one medication like metformin, okay? Obviously, if they have underlying coronary artery disease, you would like to add an SGLT2 or a GLP-1.
Dr. Rama, I think Cameron got kicked out of the Zoom, so he needs to be readmitted.
If one of you can do that, I'll be very happy. So
I think he
so I
should
just
be able
press
to.
the
now.
admit.
Yeah,
Did I kick him out?
no,
No,
you should have
you let
admitted
him
it, so hopefully he's okay.
Yeah, I'm back on now. Thanks, guys.
So again, most patients with type 2 diabetics, you would give them advice about dietary modifications, exercise on a regular basis, start them on one medication, monotherapy, which in many cases would be metformin. If they're underlying a heart disease or they've had manifestations of heart disease, you would start them on a GLP-1 or an SGLT2. If they're obese, you will start them on a GLP-1. If they're not able to tolerate metformin, obviously you start them on one of the other classes. But if for some reason they are inadequately controlled, then you can start the second medication, which is what combination therapy is all about. Metformin, you can combine it with any of the other classes of medications. Okay, just keep that in mind. Usually, unless you're combining metformin with a sulfonylurea, most of the other classes of medications are pretty expensive. So that's another thing, option you have to consider when you're considering cost savings or insurance issues, because insurances may not cover certain classes of medications. The rule of thumb is you start them on monotherapy, try and titrate the dose up till you've reached the maximum tolerated dose, then you add the second medication. Unfortunately, when you increase the dose of metformin to beyond 1,000 milligrams daily, it does decrease the appetite, which if the patient is already lost weight, that may not be the ideal thing to do. So you would add a second medication at an earlier stage. Whereas if they're obese, you can probably titrate the metformin to the maximum tolerated dose of 2,500 milligrams before you go up. You add a second medication. Again, this slide just tells you, what monotherapy is and what dual therapy is and what triple therapy is. So you can combine metformin with any of the medications in the second set of the slide, in the second half of the slide, and the second third of the slide. And triple therapy, you can combine one medication in the first group with another medication and a third medication. Insulin. Let's assume that you've started out with monotherapy. You've increased the dose to the maximum tolerated dose. You had to add a second medication. And then you decided to go to insulin, or you decided to add a third medication, still did not work, then you decide to add insulin. The average dose of insulin is 0.6 to 0.8 units per kilogram per body weight per day. Usually, half of the insulin requirement is given as what's called a basal dose or a long-acting insulin. And the other half, you divide it with meals. When you're combining it with an oral hypoglycemic, you don't have to give mealtime insulin because the oral hypoglycemic takes the place of the mealtime insulin. You just give one dose of the long-acting insulin. Okay. When I do that, essentially what I tend to do is start the long-acting insulin in the evening and titrate the dose of the long-acting insulin till the morning sugars are 150 or less. Stop at that level and then they can continue with their regular oral hypoglycemic dose. And that seems to do the trick. Remember, the long-acting insulin just affects the morning sugars. They don't do much to control the mealtime sugars. The insulin is usually injected subcutaneously, usually over the anterior abdominal wall. And what patients tend to do is they divide it into quadrants, 4 quadrants. Then they rotate the quadrants when they inject themselves. NPH is the cheapest. It's also called neutral protamine hagedorn. But then, because it's the cheapest, I'm afraid they're going to pull it out of the market in the near future. It's not going to be available any longer. The other longer acting insulin, which act for 24 hours, is the glargine insulin, the detamere, and the deglutec. The glargine is the cheapest, followed by detamere, followed by the deglutec, which are more expensive. Glargine comes as Lantus, Toujeo, or Basaglar. Detamere comes as Levemir, and deglutec comes as Tresiba. Yeah, that's right. All of them are extremely expensive. When you start them on insulin, especially when you're adding it to an oral hypoglycemic, what I tend to do is I choose a number, 10 or 15 units, and I increase it by 2 units every 2 days in the evening till the morning sugars are 150 or less, and I stop at that level. When you're needing to use more than 60 units in a day, you split the dose. You give 2/3 at night and 1/3 in the morning. And whenever you start people on insulin, remember that it's conducive to gaining weight, and it's also conducive to increasing the episodes of hypoglycemia. You cannot mix a long-acting insulin with a short-acting insulin. Okay, keep that in mind. These are the short-acting insulin or the rapid-acting insulins, like Lispro, Aspart, or Apidra. These are all analogs of human insulin. They're also called mealtime insulins. Okay. Onset is about 15 minutes. It's ideally given about 15 to 20 minutes before a meal. Peak is 1 to 3 hours and duration is 2 to 5 hours. You also have a mixture of NPH and rapid-acting insulin. It's called 70-30 or 75-25. Okay, that mixture is also available. 70-30 is a lot cheaper. 75-25 is very expensive. Many patients with type 1 diabetes and occasionally patients with type 2 diabetes prefer to be on an insulin pump. So they load their syringe and they attach it to the pump, and a small amount of insulin is infused subcutaneously or throughout the 24 hours. And you can titrate it to your CGM. So you get the minimum amount of insulin, which controls your sugars. Unfortunately, it's associated with significant weight gain because it makes you feel hungry all the time because of episodes of hypoglycemia. So you put weight on. And that increases your insulin requirement as well. Pancreatic transplant has been done in a few centers, and there are attempts at immunosuppression and hematopoietic stem cell transplants as well. But I think it's still out there. I don't think it's really available. These are the side effects of insulin: hypoglycemia, allergic reactions, insulin lipoatrophy or lipohypertrophy, insulin edema, and weight gain. Insulin lipoatrophy and lipohypertrophy occur at the sites of injection. Now, how do you titrate your therapy based on A1C levels? Generally speaking, an A1C, just to make it simpler, an A1C 8 or less, I recommend monotherapy. Some purists would say 7.5. A1C 9 or less, dual therapy. A1C greater than 9, either triple therapy or add insulin to the dual therapy. Okay, 8 or less monotherapy, 8 to 9 dual therapy, greater than 9 triple therapy, or add insulin to the monotherapy, long-acting insulin to the monotherapy. What if the diabetes affects the kidneys? Avoid NSAIDs. Aggressively manage blood glucose and blood pressure. Initiate an ACE inhibitor or an angiotensin receptor blocker if that has not already been done. Don't use them together. Continue to check their microalbumin every year unless they are already on an ACE or an ARB. In a previously well-controlled diabetic, if he starts getting episodes of hypoglycemia, pay attention to the renal function, because if the renal function is heading southwards, that may be the reason why he's getting episodes of hypoglycemia, because the medications tend to accumulate in the body and not be renally excreted. Management of diabetic retinopathy. Start with annual dilated eye exam in type 2 diabetics and within 5 years after diagnosis in type 1 diabetics. More frequent examination in women during pregnancy and the first year postpartum. Patients already diagnosed with retinopathy and patients with macular edema receiving active therapy. You can slow the progression of retinopathy by optimizing the control of blood glucose, blood pressure, and lipids. If you send them to ophthalmologists, they can do laser therapy to minimize the progression of the retinopathy. And sometimes they can also inject vascular endothelial growth factors, which will delay the progression of retinopathy. Remember, diabetes is one of the most common causes of blindness in this country, especially because of vitreous hemorrhage. They can do something called pan-retinal photocoagulation in these patients. And if you have retinopathy, you have to avoid strenuous exercises like powerlifting because it can precipitate a vitreous hemorrhage. You need to examine them neurologically every year to check for neuropathy. You need to inspect the foot. And patients need to examine their feet every day, and they need to look after their feet as well as they look after their face. Also check them for autonomic neuropathy. Neuropathy can be extremely painful. Most patients with neuropathy have tingling and some numbness, and they are at an increased risk of injury. But neuropathy can be extremely painful. The tingling and numbness, unfortunately, you cannot reverse with medications, but pain can be controlled by medications. And some medications are amitriptyline, which is a tricyclic antidepressant, or venlafaxine or gabapentin, or topiramate, or other medications that can be done, can be given. Occasionally, you may have to put them on narcotics like tramadol or morphine or oxycodone. Patients with diabetes 40 and over need to be on a statin, need to be on what they call a moderate intensity statin. If they have established coronary artery disease, they need to be on a high intensity statin. Patients who are diabetic but less than 40, if their LDL is 190 or over, they need to be on a statin. Okay, keep that in mind. Patients with diabetes 40 and over need to be on a moderate intensity statin, unless they have established coronary artery disease, when they need to be on a high intensity statin. Patients with poorly controlled diabetes can also have elevated triglycerides. And if their triglycerides are over 500, they need to be on a second medication to control the triglycerides, because statins control LDL, they don't control triglycerides. This question is for you. Which of these should be given to a patient with hypoglycemia with severe symptoms? What do they give in the hospital? Which is part of what they call the hypoglycemic protocol. It's IM glucagon. Apple juice and apple candy will all increase your blood sugar, but it increases it very slowly. Glucagon given orally is just digested in the stomach, it doesn't work. It's not effective, which is why they need to be given IM glucagon. The other method of dealing with it, of course, to give them IV dextrose. That's what they do. EMTs, they don't give IM glucagon, they give IV dextrose. Any questions on diabetes? We are jumping to a different topic. Okay. According to the JNC8 criteria, which of the following patients needs treatment for hypertension? Let's simplify JNC8. What is the magic age? What is the age cutoff? It's 60, okay? So find out if your patient is 60 or over or under 60. In patients 60 and over, the accepted blood pressure is 150/90. In patients under 60, the accepted blood pressure is 140/90. Now, the next parameter is, does he have renal dysfunction or does he not have renal dysfunction? If he has renal dysfunction, just reduce everything by 10. Okay? Over 60, 150/90. Under 60, 140/90. Renal dysfunction, 130/80. Okay? Just remember these three numbers. You don't need to remember anything else. So based on the information I've given you, which is your right answer? Piece of cake? Now, there's a little more information. If you forget it, that's fine with me. Normal is less than 120/80. Elevated means systolic between 120 to 129 and diastolic less than 80. Stage 1 hypertension is a systolic between 130 to 139 and diastolic between 80 to 89. Stage 2, systolic at least 140 or diastolic at least 90. There is a condition called hypertensive crisis when you have a systolic over 180 and a diastolic over 120. Okay. But this is exactly what I told you. Okay. JNC's practice guidelines. Cutoff is 60, over 60, 150/90, under 60, 140/90. If there is renal problems, 130/80. That's your goal blood pressure. Now, they did make some changes. The ACC/AHA guidelines of 2017 did make some further recommendations. I just want you to be aware of these slides. But the AAFP decided not to endorse these changes because it is not based on any clear-cut evidence, which is why we are still sticking to this, with 2014, and we are not adopting the 2017 guidelines. Okay, I just wanted you to be aware if somebody tells you this is out there. But this is not based on randomized controlled trials, which is why the American Association of Family Practice decided not to endorse this. Why would you treat hypertension? Because bringing the blood pressure back to normal reduces the risk of stroke, MI, and heart failure significantly. Most patients with hypertension initially can be controlled with one medication, but if the rise in blood pressure is 20/10 above goal, please consider starting them on 2 medications at the same time to get better control. Okay. So initially, you will be able to get good control with one medication, but if the presenting blood pressures are higher, for example, 20/10 above goal, consider starting them on more than one medication at the same time. And obviously, you have to pay attention to the patient's socioeconomic status and psychosocial stressors as risk factors before you choose the management model for that patient. I mean, for example, if somebody is having a hand-to-mouth existence, you will not start them on a more expensive medication just because it works better. And always try a combination pill, because the less frequently a person has to take the medication, the more likely he is to adhere to the treatment regimen. Can you think of a combination medication for hypertension?
Like metoprolol or lisinopril or some sort of ACE inhibitor. Or like
Yeah, lisinopril HCTZ is one. It's the most common combination. Okay. The other one is triamterene HCTZ, diazide. So when you, instead of starting him on two different medications like lisinopril or losartan and HCTZ, you give the combination medication lisinopril HCTZ or losartan HCTZ. He's much more likely to take it because it's a once-a-day medication. Okay. This question is for you. Which of the following agents is first line for most patients presenting with hypertension and no comorbidities? What do you think is the right answer?
P.
That's right, hydrochlorothiazide. It is a diuretic, and it's one of the cheapest medications available, cheaper than dirt. And it's, interestingly enough, it works very well in most patients with mild hypertension. And it lends itself to be compared with other medications as well, like an ACE or an ARB. Or a potassium-sparing diuretic. That's what diazide is. Thiazide reduces sodium reabsorption in the distal convoluted tubule. It also reduces the excretion of calcium, which is why it is favored in the elderly, because it helps them retain calcium and decreases the risk of osteoporosis. It reduces the excretion of uric acid, which unfortunately does precipitate gout. And it also reduces the excretion of lithium. So if the patient is already on lithium, then it does increase the risk of lithium toxicity. It does increase the excretion of potassium, favoring hypokalemia, and magnesium, favoring hypomagnesemia. So remember, in elderly patients, you have to do their electrolytes on a regular basis to check their electrolyte levels and make sure that their electrolytes are not depleted if they are on a thiazide diuretic. Fortunately, the amount of glucose that accumulates because of thiazides is not much. And diabetes is not a contraindication to the use of thiazides. It's typically considered ineffective, and the GFR is less than 30 millimeters per minute. So in stage 4 CKD, it doesn't work. Neither does chlorthalidone. Which diuretic works in renal insufficiency? Which is the diuretic of choice in patients with kidney failure? Furosemide, that is correct. Which thiazide diuretic is used in renal failure? For a bonus point. It's often combined with furosemide.
Metolazone.
Very good, metolazone. Yes, metolazone is the only thiazide diuretic which works in the presence of renal insufficiency. It's not used in isolation, but is combined with furosemide. It enhances the activity of furosemide. Maximum dose is 50 milligram, but After 25 milligram, it doesn't seem to work well. 50 milligram just increases the risk of side effects. This class of medication is recommended first line for hypertension in African American patients. That is correct. Calcium channel blockers. ACE inhibitors or ARBs for some reason don't work as well in African American patients. So it's not recommended even in diabetics in Africa, if you're an African American, unless you have renal insufficiency. Keep that in mind. You have two classes of calcium channel blockers, dihydropyridines and non-dihydropyridines. The non-dihydropyridines slow AV nodal conduction. They're also used in arrhythmias, tachyarrhythmias, and in coronary artery disease. The dihydropyridines have no effect on cardiac contractility or AV nodal conduction. They produce vasodilatation, which is why they can cause headaches and pedal edema and facial flushing and things like that. But they do decrease your blood pressure. Amlodipine is most commonly used. The most common side effect of amlodipine is pedal edema. This class of medication is recommended first line for hypertension in diabetic patients. And the answer would be ACE inhibitors or ARBs. That is correct. They are nephroprotective. They delay the onset of nephropathy. It slows the progression of microalbuminuria in diabetic patients. But they should not be combined. ACEs and ARBs should not be combined. An ACE-induced cough can occur in 10 to 20% of the patients due to bradykinin accumulation. Okay. And if you have an ACE-induced cough, you can switch to an ARB, but occasionally remember that ARBs can also cause a cough. And these are your various doses. Lisinopril is the most common ACE that is used. The others can also be used. Losartan is probably the most common ARB that is used. Candesartan has taken on a little more prominence recently. Why is that? What else is it used for? As a prophylaxis in migraine. Okay, as a prophylaxis in migraine, which is why candesartan has also taken off recently. The others are used rarely. Valsartan occasionally I've seen, and olmesartan. I haven't seen people use irbesartan. Which of these medications can be used for arrhythmias? And again, this is not a very good question because it has more than one right answer, but I think the answer they're looking for is beta blockers. Why? Because we already discussed calcium channel blockers. But calcium channel blockers can also be used for arrhythmias, but beta blockers are favored. Because most common cause for arrhythmias in the elderly is coronary artery disease, ischemic heart disease. Metoprolol is available as a tartrate and a succinate. The tartrate is short-acting, usually given twice a day, and that's better for rate control. The succinate is long-acting, taken once a day, and it's better with controlling blood pressures. Coreg is favored by the cardiologists, and it's part of what they call GDMT, or goal-directed medical therapy, in patients with congestive heart failure. And it's especially useful in both systolic and diastolic dysfunction. Codec has to be titrated very slowly. You start patients on 3.125 milligram, and a week later increase to 3.125 milligram twice a day, and a week later you increase it slowly. A variety of medications can be used in hypertension with the presence of ischemic heart disease, like ACEs, ARBs, beta blockers, long-acting calcium channel blockers. Long-acting nitrates can also be used. They do reduce blood pressure to a small extent, not to the extent that the other classes of medications reduce the blood pressure. These are the other classes of drugs which are available called aldosterone antagonists. They are also part of the goal-directed medical therapy in patients with congestive heart failure, and they can also be used in patients with resistant hypertension. And you call resistant hypertension where you're using 3 or more classes of medications to control hypertension. One of them should be a diuretic. And in spite of that, if the blood pressure is not being controlled, aldosterone antagonists can be considered. The other places where you can use aldosterone antagonists is when you have secondary hypertension due to Cone syndrome, hyperaldosteronism. And the third place where you use aldosterone antagonists is in patients with cirrhosis who have ascites. Do you all know the 5 F's of abdominal distension? The 5 F's of abdominal distension. Take a wild guess.
It's one fluctuance.
What's that?
Fluctuance.
5 F's. One's fluid. Ascites, we talked about F. Ascites, that's fluid. What are the other F's of abdominal distension?
Fat.
Fat. What else?
Like fertile pregnancy.
Fetus.
Okay. Close enough.
What else?
Flatus.
Flatus. Very nice. What else? Which is the 5th F? Guy's constipated. Feces. Okay, 5 F's of abdominal distension. Remember that. Okay, fun fact. See, both F's, fun fact. Eplerenone is very expensive, hardly ever used in the ICU. This is a slide worth paying a little bit of attention. And the reason I bring this up is you can choose your antihypertensive therapy based on the comorbidity that the patient has. For example, he has a congestive heart failure with reduced ejection fraction. You can choose an ACE or an ARB or a beta blocker. If he has had an MI, again, an ACE or an ARB. Proteinuric chronic kidney disease, ACE or an ARB. Underlying angina, calcium channel blocker or a beta blocker. Atrial fibrillation with rate control, again, a calcium channel blocker or a beta blocker. Atrial flutter with rate control, calcium channel blocker or a beta blocker. BPH, an alpha blocker, like Flomax springs to mind. Essential tremor, beta blocker, like propranolol. The other one, medication which is used as primidone in essential tremors. Hypothyroidism, beta blocker for rate control. Migraine, we talked about calcium channel blocker and beta blocker, propranolol, and candesartan. Osteoporosis, thiazide diuretic. Why? It decreases calcium excretion. Raynaud's phenomenon, peripheral vasospasm. You want a peripheral vasodilator like amlodipine. This slide tells you what the side effects are. Contraindications. They have already had an episode of angioedema. Don't use an ACE inhibitor. Remember, ARBs can also cause angioedema occasionally, though not to the same extent as ACE inhibitors. Significant bronchospasm. Don't use a non-selective beta blocker. Okay. Liver disease, avoid methyl dopa. Pregnancy, don't use an ACE or an ARB because they are teratogenic. They already have a second or third degree heart block. Don't use a medication that slows the heart rate, like a calcium channel blocker or a beta blocker. They are already depressed. Don't use a beta blocker or clonidine. They have gout. Don't use a medication that increases serum uric acid, like a thiazide diuretic. They are already hyperkalemic. Don't use a potassium-sparing diuretic or an ACE or an ARB. Interestingly enough, if you have recurrent hyperkalemia, the first time you have hyperkalemia, you can reduce the dose of ACE or an ARB or temporarily discontinue it. But the second time they develop hyperkalemia, ACE or ARBs are out. If they have hyponatremia, generally avoid a thiazide or a loop diuretic. Especially remember, elderly patients can be significantly sensitive to thiazide diuretics. They can cause significant hyponatremia. They can present with sodiums in the 120s and 115s. And they need to be admitted, and slowly they need to be replenished. If they already have established renal dysfunction, try and avoid an ACE inhibitor or an ARB. There is something called an ACE effect. You start a patient on an ACE inhibitor, what happens to the renal function? It decreases. Okay, the creatinine can go up to 15% and occasionally up to 20%. They already have established renovascular disease. Try and avoid an ACE or an ARB. This question is for you. Which medication causes patients to feel tired? That's correct, beta blockers. Why is that? Slows the heart rate. It slows the heart rate. Interestingly enough, the benefit is by reducing the heart rate, it decreases the oxygen consumption by the heart. But you're on a beta blocker, you're up and running, trying to get through your clinic. What happens, of course, is your heart rate and the oxygen requirement cannot keep up with your requirement, which is why it makes you feel tired. Again, this medication causes a cough and angioedema. That's your ACE inhibitors. And this medication causes leg cramps and potassium abnormalities. And again, this is not the best question because there are two potential answers here. The loop diuretics and thiazide diuretics, both of them can cause leg cramps and potassium abnormalities. So if you answer one of them, I think you should be fine. And which one of these medications can be used for arrhythmias? Again, this is not a very good question because you have more than one answer. You can use both beta blockers and calcium channel blockers. And this slide just tells you what the various side effects are, and I'll let you read it at your own convenience. Okay. I think we're done. Thank you very much for your attention. Any questions? Okay. You all have the slides, don't you? Did they give you the slides already?
Yeah.
Okay.
Yeah.
Thank you very much. Really appreciate it.
for submission or something like that. Okay, gotcha. So you can send her an email and.
Perfect, thank you.
The only thing we have to, let's do dates, I don't do anything, right? Yeah, just maybe from one.
And don't forget, to, be entering your PC log and to review all the stuff when you have time. I'll send out a reminder email